Welcome to This Explainer. Today, we're undertaking a practical, highly structured clinical masterclass. We're going to take something you probably do dozens of times a week, writing a prescription, and elevate it from a routine administrative task to a true masterclass in precision. By the end of this session, you're going to look at that small rectangular pad in a completely new light.
A perfect prescription is really the ultimate standard of patient safety. It's the direct, tangible link between your diagnostic chair and your patient's therapeutic outcome. To guide us, we're anchoring today's explainer on the rigorous clinical standards set by experts in the field. Specifically, we'll be looking at the structured approach championed by Dr. Dirk J. Buyason, and his rule of thumb here is simple but absolute. The more thorough, the better. Oh, and of course, make sure it's actually legible.
Okay, let's dive into this. Today, we'll cover 4 main areas: the anatomy of a prescription, the big 3, navigating South African drug schedules, and finally, the ICD-10 code and legal checklists. Section 1. Anatomy of a prescription. We've got to dissect a prescription pad exactly like we would an ocular structure. Every single line, box, and symbol on there has a dedicated physiological role in the life cycle of that piece of paper. Now, before we even get to the drugs themselves, take a look at the top. The patient and practitioner information form the absolute vital header of our document. This is your patient's name, their current address, the date the prescription is written, and on your side, your practice information and license details. Without this precise header, the document literally has no legal foundation. Right below that header, we find the superscription. You definitely know this one. It's the classic RX symbol. But what's fascinating is that this is actually an ancient symbol associated with healing. It's a contraction of the Latin verb recipe, which translates to take thou or you take. So it's essentially this formal historical command initiating the therapy. Pretty cool, right? Moving on to section 2, the big 3. So if the header is the chassis of the prescription, this next section is the core operational engine. This is where your specific clinical decisions are recorded and translated into real-world action. First up in the big 3 is the inscription. The level of specificity required here is absolutely key. This is the primary body of the prescription, where you specify exactly what chemical the patient needs. You've got to include the name of the drug, whether that's the generic or the brand name, the exact concentration, and the formulation. Are you ordering a solution, an ointment, a capsule? The inscription leaves zero room for guessing. Immediately following the inscription is the subscription. Now, this part isn't for the patient. This is a direct communication from you to the pharmacist. You're telling them the exact quantity to dispense. This could be the number of dosage units, the volume of a solution, or the size of an ointment tube. You generally want to prescribe the absolute minimum quantity needed for the treatment duration, mostly just to avoid unnecessary or unwanted use later on. And rounding out the big 3 is the signatra, or what we commonly just abbreviate as the SIG. These are the specific directions for patient use. It covers the route of administration, the number of drops or tablets, the frequency, and the overall duration. Now, while writing these instructions out in plain English is definitely trending for the sake of clarity, traditional Latin abbreviations are still incredibly vital to know. Things like BID for twice a day or QID for 4 times a day. These instructions are exactly what the pharmacist is going to print on the bottle's label for the patient to read. All right, section 3, navigating South African drug schedules. So that covers the physical structure of the paper. But now we're shifting gears to the specific legal parameters governing what you can actually prescribe in South African optometry practice. Notice the escalation of drug control here as we move down the list. We start at Schedule 0, which are your simple analgesics, stuff you can just grab off the shelf at a general supermarket. Schedules 1 and 2 step up to over-the-counter pharmacy items. And for Schedule 2, the pharmacist actually has to keep a sale record. But the real shift, the big leap, happens at Schedule 3 and Schedule 4. These are prescription-only medicines. They require a professional diagnosis, a management plan, and they are dispensed strictly from the pharmacy dispensary. And this brilliantly illustrates the crucial distinction for a prescribing optometrist. When comparing Schedule 3 and Schedule 4, you're really looking at the heavy lifters of clinical management. Schedule 3 might cover systemic conditions managed over a longer period, like hypertension or diabetes. But Schedule 4? That is where you find your critical anti-infectives, your targeted antibiotics, antivirals, and antifungals. These are the schedules where your diagnostic accuracy directly dictates the chemical intervention. Let's see how this builds into a concrete clinical example. Say you diagnose a patient with trachoma. Your therapeutic intervention is going to require scheduled anti-infectives. Depending on the severity and the overall clinical picture, your prescription will specify either a topical application, like a tetracycline ointment, or an oral route of administration, like doxycycline. This right here is where your knowledge of the drug schedule directly impacts the patient's recovery.
Finally, Section 4, the ICD-10 code and legal checklists.
Okay, so we've written the instructions, we've selected the scheduled drug, but if we don't follow the strict legal requirements, the entire prescription is invalid. These rules are there to protect both you and the patient. First, let's talk about effective writing rules, and I'm going to put my mentor hat on for a second to warn against some incredibly dangerous pitfalls. Absolute legibility? That's non-negotiable. But perhaps the most critical safety rule is avoiding what we call the naked decimal. You must always write 0.25, never just 0.25. If a pharmacist misses that tiny little dot, your patient could receive a massive, dangerous dosage error. Also, strictly avoid vague instructions like take as needed. Be precise. Tell them exactly how much, exactly how often, and for how long. Beyond just the writing rules, mandatory practitioner details are what validate the order. Remember, a prescription isn't a suggestion, it's a legally binding order. Because of that, it has to boldly carry your signature. On top of that, it must include your physical practice address and direct contact information, like a telephone or fax number. Think about it. If the pharmacist spots a potential contraindication, they need to know exactly how to reach you instantly.
So the crucial point is this absolute requirement, the ICD-10 diagnostic code. In South Africa, you simply must add the appropriate ICD-10 code to every single prescription you write. This code is what clinically justifies the scheduled medication you've selected. Leaving off the ICD-10 code literally renders the prescription incomplete and legally non-compliant. It's basically the final lock on the door of your clinical decision-making.
Which brings us to the end of our masterclass and leaves me with a question for you to ponder. When you reach for your prescription pad later today, ask yourself, is your next prescription just a piece of paper, or is it a legally bulletproof extension of your clinical care? Keep these structured standards in mind, protect your patients, and elevate your practice. Thanks so much for watching this explainer, and keep learning.